Diseases accompanied by heart murmur syndrome, congenital heart defects, indications for surgical treatment, prevention, follow-up care, and rehabilitation. First, let's look at what they are. Heart murmurs are relatively prolonged sounds that occur due to turbulent blood flow. Turbulence arises when the balance of three hemodynamic parameters is disturbed. Here you can see the mechanisms of heart murmur formation. Laminar blood flow under normal condition in picture A, turbulent blood flow due to narrowing, picture B, dilation of the vessel lumen in picture C, and the presence of an obstruction in the path of blood flow in picture D. Heart murmurs can be intracardiac, extracardiac. The ones we will be looking at are organic and functional ones. Organic murmurs arise as a result of significant organic damage to the heart valves and other anatomical structures of the heart. They are observed in heart defects. Defects by type of anatomical lesions can be valve insufficiency, mitral, and aortic. Defects by type of anatomical lesion can be of the following. Characteristics of heart murmurs. They can be systolic murmur, diastolic murmur, area of maximal auscultation, combination with changes in heart sounds, murmur conduction, etc. Systolic murmurs heard together with or after the first heart sound during the short systolic pause. They coincide with the apex beat and carotid pulse. They can be organic and functional. Here you can see organic systolic murmur in the pictures. Diastolic murmurs are called organic ones. They are heard after the second heart sound during the long diastolic pause and do not coincide with the apex beat. Here you can see how they look. Characteristics of heart murmurs. Duration of the murmur to the phases of cardiac activity, systolic murmur, diastolic murmur, combination with changes in heart sounds, duration, etc. Area of maximal auscultation at the apex of the heart in lesions of the mitral valve, in the second intercostal space on the right and at Botkin-Erb's point, in the second intercostal space on the left, at the base of the ixoid process. Characteristics can be systolic, diastolic, area of maximal auscultation, etc. Murmur condition. A harsh systolic murmur in aortic valve stenosis is conducted along the direction of blood flow and the carotid and subclavian arteries and in the interscapular region. Let's move on. Here you can see their characteristics, the same as the previous ones, and character and timbre of the murmur. Organic murmurs may be soft, blowing, harsh, scraping, and soughing. Functional murmurs are usually soft. Musical murmur occurs with the followings. Intensity and loudness of the murmur depends on the velocity of blood flow, the preservation of sufficient contractile strength of the heart, and the degree of narrowing. Intensity and loudness of the murmur. Systolic murmur in aortic valve stenosis is sharp, loud, and strong. Presystolic murmur in mitral stenosis is usually soft. A phonic defect with severe narrowing of the left orifice, the diastolic murmur may disappear. Characteristics are the same. Duration and shape of the murmur can be seen in the following picture. Patient's position. Systolic murmurs in mitral and in stenosis of the aortic and pulmonary orifices in the supine position. Relation to the physical exertion and respiration. Organic murmurs become more pronounced after physical exertion. Increased blood flow velocity. Organic murmurs intensify during exhalation. Here you can see systolic murmur at the apex. mitral valve insufficiency. It can be quite harsh. It radiates to the left axillary region. Systolic murmur at the second and the fifth auscultation points. Diastolic murmur at the apex, mitral stenosis. Diastolic murmur at the apex occurs after the opening snap of the mitral valve, associated with the quell rhythm, accentuated first heart sound, second heart sound, and mitral valve opening snap. Here you can see aortic insufficiency. And the systolic murmurs at the third and the fourth auscultation points, most often conducted or functional. However, it may also occur with congenital heart defects, pulmonary artery stenosis. Functional murmurs are not based on significant structural abnormalities, but rather on functional changes, accelerated blood flow, and decreased blood viscosity. Functional murmurs can be dynamic, anemic, and dystonic. Functional murmurs, a formation of false chordae, disproportion in the growth of heart chambers and great vessels, murmurs associated with the movement of the pulmonary trunk around the aorta during right ventricular systole. Heart murmurs, as structured in the table, signs of a murmur relation to the phases of the cardiac cycle, organic murmurs, systolic and diastolic, and functional murmurs, systolic. Organic murmurs are loud, functional murmurs are soft, and functional murmurs are also more gentle, more common in young individuals, and often heard over the pulmonary artery and the apex. On the other hand, organic murmurs depend on the affected valve. The patients are young and elderly, and is quite harsh. So here you can see another table of functional murmurs and organic murmurs and the sign of them. Like duration, organic murmurs are more prolonged, while functional ones are short. Irradiation radiates beyond the heart is organic murmur, and the functional murmur is not conducted beyond the heart artery area. Here you can see the presystolic Flint murmur. Extracardiac murmurs, they can be pericardial friction rub, and they are caused by deposition of fibrin, aseptic pericarditis, and severe dehydration and uremia. I think this is all for today, and see you next time.